Okay, so I have the huge privilege of introducing Kate Scarlata, who has come all the way this afternoon, today, or earlier this week, from Boston. She clearly is well renowned internationally with respect to her work in digestive health. It's a huge privilege to have her here today. She's published a number of books, including The Complete Idiot's Guide to Eating Well for people with IBS. So that sounds a really interesting read and one for us to look at. So I think to me, besides her expertise with respect to gut health, she also is very strong in patient advocacy as well. So the two combined, as perhaps I indicated earlier, I'm hugely concerned about health inequalities. It's, I feel, really something we often overlook. So the State of Heart talk that Kate's going to deliver to me is of particular interest, looking at the intersection between food security and food intolerances. So welcome, Kate.
Thank you so much. It's so great to be here. Really, thank you for the invitation. So yes, I've been tasked to talk about the intersection of food intolerance and food insecurity. And this graphic I just want to share is by a colleague. I created an initiative called the End Hunger Pain, which you'll hear more about. And she did this graphic along with another colleague who has an organization called the Food Dignity Movement, really identifying the role of stigma and that everyone deserves to eat healthy food in a welcoming environment that works for them. So let's just start with food insecurity and understanding of what it is. It's not hunger. So hunger is the physiological feeling of feeling weak and needing food. Hunger can be a consequence of food insecurity, but food insecurity really is limited or uncertain availability of nutritionally adequate and safe foods, or the ability to acquire acceptable foods in socially acceptable ways. I really want you to think about that, like what would be socially acceptable to you. There was a gentleman that started a store out in Boston in a very low-income area, and he thought this would be great. He was taking in food that was near expiration date and making it inexpensive to the locals that lived in that area. And on paper, it sounded wonderful. But when they involved the community members, they hated it because it was only accessible to people with low income. So walking in there, they felt stigmatized. They also learned from this group that fresh fruits and vegetables are great, but when you're working 3 or 4 jobs, you really need a quick meal to feed your children. And so they really listened to the community and developed, actually they created wonderful soups and stews that were easily acceptable to that population. So bringing the community in, understanding what their needs are, and understanding that this is a highly stigmatized place to be. It's very obvious that you can't afford food to feed your family. So food insecurity does run a gamut. There's mild food insecurity. This is an uncertainty about your ability to obtain food. Will I have enough money? But then it can really lead to moderate, which is really a decline in the quality and variety of food and the nutritious nature of food, and the possibility that you need to skip meals in order to manage your food requirement for the day. And then translating into severe is when you're skipping meals or no food available for a whole day. I can't imagine that. But when we think about that moderate to severe food insecurity, it's been globally on the rise since 2014. And North America and Europe has been relatively unscathed, but if you look at the other parts of the country, Africa and Asia and Latin America, this area of moderate to severe food insecurity is really quite significant. And with food insecurity comes health risks. So we see in children that food insecurity is associated with a risk of birth defects, anemia, lower nutrient intakes, higher risk of being hospitalized, increased risk of asthma. And adults are more likely to experience obesity, which seems somewhat like a paradox, but if you're eating inexpensive, very calorie-dense foods as a mean to get by, that often can lead, as well as low nutrient intake. And there's increased challenges with managing conditions, right? Do I get the medication to treat my diabetes, or do I get the food? So there's really been shown to be lower self-efficacy in managing chronic conditions with patients or individuals with food insecurity. And then just barriers to healthy eating. We're trying to work 3 jobs like we learned in that community market in Boston, and lack of, competing priorities, cost of food. So talking about cost of food, normal inflation rates are about 1.8%. In America, they're around 8%, and I think the UK, they're 8.7%. So you can see it. I remember I hadn't really been to the grocery store for a while, and I went to buy a dozen eggs, and they're $9 US dollars. I'm like, what? So, if you don't have money, you can see how this just is a real struggle for many of our patients. And then we have to discuss food deserts and food swamps in this discussion. And food deserts really, little access to high-quality grocery stores in places that you live. And we have many, I'm sure you do here in the UK, but many rural areas where you may have to travel 2 or 3, 4, 5 miles to a grocery store. And alternatively, you have the food swamps. And these really, they call it like a food apartheid, really, where low-income areas are targeted, and all these fast food, junk food, establishments hit the ground running because they're going to serve this population. But unfortunately, the food swamps are associated with obesity and poor diet. And then when we look at racial disparities, you can see on the graph to the left here, when we look at households, the prevalence of child food insecurity amongst variety of different ethnic and racial groups, you can see that in the Black and Hispanic, at the end of the teal here in 2020, dramatically going up. So we're really seeing a rise in certain racial ethnicities. We also know that women with food insecurity are more likely to be obese, and the hypothesis is that women tend to feed the healthy foods to their children and get by with what they need to. They also are shown to have less nutrient intake. We know that malnutrition in larger bodies is really not always addressed. We see this in eating disorders as well. If you're in a larger body, it's not escalated. Lots of downstream effects and consequences to food insecurity. I've addressed some of these, but you can really see the distress and the stigma associated with that as a downstream effect. Hunger, of course, nutritional value, and then a number of effects, children, weight faltering, again, the sort of paradox of obesity, lower educational achievement, developmental deficits. And the US is now doing a lot of studies looking specifically at the college education age level, and they're seeing really high levels of food insecurity in students, which is not surprising. And often they don't have vehicles to travel to a grocery store, so they're living off trail mix and chips and who knows what else, right? And more recently, this was a really well-written paper from my perspective, my bias, but I highly recommend this if you're interested in this area. This is really looking at the relationship between food insecurity and eating disorders. And what they found was that food insecurity is cross-sectionally associated with bulimic-like tendencies. And they hypothesized that it's sort of this feast or famine. A lot of the supplemental nutrition programs in the US, they get 1 month, every month they get their dividend. So they get all this food and they're all psyched and they're eating a lot, and then it's, lost again. And it really is associated with food preoccupation. And additionally, also with, cognitive, emotional, and behavioral effects, which is not surprising. But very, very well-written paper. So I want to talk a little bit about social determinants of health because this weaves in and out of food insecurity. Food insecurity is one way social determinants of health really can impact health. So these are really the conditions and environments in which one lives and how that impacts their health outcomes. And a large-scale study in the US, I'm noticing like my glasses are probably worse on with this down here, in a large-scale survey, and it was about over 5,000 people. They found that the lower the household income, the greater the frequency of DGBIs, such as IBS, and the more the severe symptoms. So connecting again, and you could see how binging could impact IBS symptoms as well. So it's all kind of threaded through. I did talk about this a little bit in our session, but this was a study. It's unpublished. We're working on getting it published. Everyone's just been busy, to be honest. But we were looking at social determinants of health and how that related to who was referred to a low FODMAP diet. And we found that in those with less than a high school diploma, household income was less than $75,000, and decreased food access, they were statistically significant, less likely to be recommended a low FODMAP diet. And I'm sure if I talked to each and every one of you, you would have a reason why that might be. And you're probably all right. It's very nuanced here, but it does really show you that social determinants of health are affecting health equity when we know this is an effective dietary treatment for IBS. So this is a big problem, and it's occurring in many of our patient populations. So I'm hopeful that you're screening for this. In the US, we use the Hunger Vital Sign. It's just a two-item screening question. We worried whether our food would run out before we got money to buy more, or the food that we bought just didn't last and we didn't have money to get more. If they answered often true or sometimes true, they're highly likely to be experiencing food insecurity. And then the food insecurity experience scale is another option that one can use. I know that may be used here. It was used in this UK analysis. This is an 8 questions, so a little bit more time consuming to assess for food insecurity as well. So in this particular report, they looked at severe food insecurity in a sample of 2019 compared to another analysis that was done between 2016 and 2018. And they found an increase of 66% in severe food insecurity in the UK. So it's the severe group that's really merging and getting bigger. So how do we deal with living with food intolerance with the complexity of also living with food insecurity? And I would say we're doing a really poor job at this. And again, this is another image created by Rebecca. How can we get foods in the right hands? So it's one thing to send someone to a pantry or to work with industry and say, will you send these low FODMAP foods to this pantry? But is the pantry giving the low FODMAP foods to the people that need the low FODMAP foods? And are these pantries willing to even do that because they're not a medical establishment? So there's a lot of complexities around this. And we also know that this whole financial burden for the patient is quite significant. So looking at a study that was done by my colleague Ann Lee from Columbia, she looked at the financial burden of gluten-free foods, and she found that overall gluten-free products were 183% more expensive. Looking at gluten-free wheat-free products versus wheat-based versions, 139%. And the availability of gluten-free foods were mostly found at these upscale establishments, grocery stores, as we see, right, Whole Foods that would have a great variety, which tend to price out a lot more. And then Christopher Ma has done some work in food insecurity. He looks specifically at celiac disease to see how relevant is food insecurity in this patient population. And he found 1 in 6 with celiac disease are food insecure, and this negatively impacts their ability to follow the gluten-free diet. Less than 1/4 of food insecure celiac disease patients follow a gluten-free diet. Say that to the back of the room. Less than 1/4 of food-insecure celiac disease patients follow a gluten-free diet. The only treatment that we have for these patients. This is not an official study, but I wanted to just do an Amazon look. I'm going to look at products that normally have high FODMAPs in them, and I'm going to look for a low FODMAP version and a traditional version, and just compare the price points per ounce. So again, very biased selection sample. However, you can see the traditional price pasta sauces, chicken broth, salsa, garlic-infused oil if you made it yourself, compared to these very high-end prices, especially for something like marinara sauce. You're not using an ounce on your dish. You're using a lot more. So keep in mind, per serving, that's going to be quite significantly different. But about, really significant increases when you get into specialty. So is the low FODMAP food diet for just the wealthy, remains to be seen, but it can be quite more expensive. So what about the pantry? What's there? Well, in my work to establish this plan of going out and making some noise about this intersection, I wanted to know what was at the food pantries. So I went and visited some of the local food pantries. And you see the same thing. I can remember the first one I went, I have had intestinal surgery, and I am definitely onion sensitive. And I walk in, and they just had this huge box of onions. And I'm like, oh, and I'm sure, 85% of people do great with onions, but, it was like, this is what they're offering. But they're also offering a lot of canned beans, soups, pasta sauces, bagels, wheat, things that are not suitable for our gluten-free and low FODMAP patients. And this paper it was a systematic review really looking at, it was a mixed method where they looked at quantitative and qualitative studies, looking at the food parcels, what was being given out, were they nutritionally adequate? And they found that they were inconsistent at meeting nutritional needs, often failed to meet individual needs, and really did not address cultural or health preferences. And I will say again, some of the limitations. I visited recently a food pantry local to me, and we had a lot of refugees in this area, and they had bundles and bundles of fresh broccoli. And I thought, this is awesome, fresh produce. No one was taking it because they were from Afghanistan and various places that didn't know what broccoli was, didn't know what to do with it. And so then they really had to ask the questions, teach them how to cook it. It's delicious, and they started taking it. But the cultural relevancy is also obviously very, very important. So during the pandemic, and I guess just being who I am, I'm always thinking, who am I and why am I here? And that comes to sort of the notion of life purpose. So looking at skills and passion, I'm very passion-driven, core values, talents and gifts, and where is your life purpose is right there in the center. And I feel, dietitians are in such a powerful role to make a huge difference in so many people's lives. Food is integral to many decisions that we make every day. And your skills and passions and values can really impact people on so many levels. And sitting there during the pandemic, I had this real kind of light bulb moment that my daughter would say, "You are crazy, Mom." And I'm like, I'm doing it, which is kind of classic. But I said, I really want to raise awareness. This is a problem. My people are not getting food, and more people are hungry, and the pandemic is really making a difference. And how can we really get loud, and how can we make a difference and strike up conversations and open up this intersection to more people? And so I came up with the End Hunger Pain Initiative. And as I do, I wanted it to be splashy, so I wanted an Airstream, and I wanted to rent a really cool truck, and we were going to get stickers, put them all over the truck, and we're going to fill this Airstream with food. I'm not camping in the Airstream. I'm in a hotel. But I'm going to fill it with all the industry partners that I know, and how can I get these industry partners on board? So really using my skills and connections at that juncture in my life. So here we are, I'm in the Airstream being me, and we filled that whole thing top to bottom. We had all sorts, so many companies. Shar, we had 88 Acres, which provides a seated bar, which was allergy friendly. There's about 5 food pantries, by the way, in the US that meet gluten-free or allergy-friendly needs. Kind of a problem. Allergies was top on my list as well. The picture of me is on the left here is with a group of medical doctors, dietitians, et cetera, at a low-income clinic, and I brought food to them too, so they could give it to their patients, and also open up some dialogue on how they were dealing with patients with food insecurity or limited social determinants of health. And they said they were giving out farmers market vouchers for food insecurity, and it was a great way to get fresh fruits and vegetables. But the patients, they didn't want it because the farmers market was uppity. They didn't feel comfortable, and they forgot to bring the people that are going to value from these interventions. They didn't bring them to the table. And it's so important to bring these individuals to the table. They also told me that low FODMAP would never be provided because most of their patients couldn't read. And so in 5 minutes, I went onto Canva and I did a little picture graph. And I said, could you use something like this? It's not evidence-based, but is this a step in the right direction? Can we meet patients where they are? Instead of putting further gates in front of their already limitations, we need to think out of the box. This took me 5 minutes. It could be lead someone down to only eating those foods on the top of the list and be the worst thing possible, or perhaps it opens up some dialogue and actually does help patients by eliminating some garlic and onion and wheat. So on our tour, we garnered a ton of attention. I was on 2 news programs. We were featured in the Chicago Tribune, and it was a lot of fun and a lot of craziness, especially during a pandemic. But I wanted to take a moment and share a video with you as a little recap of what we accomplished and just the journey, because it really, to me, it was a really touching time. And I brought my 25-year-old son, who was my videographer, and my husband, and I think it was really a life-changing moment for them as well. And hopefully this doesn't come in too loud. The purpose of the End Hunger Pain Initiative was to raise awareness of the growing rate of food insecurity in America and how it disproportionately impacts people living with food intolerance. It's a stigmatized condition. They're embarrassed to talk about gas and bloating. Onion and garlic free. So for people that have onion and garlic sensitivity, reflux, IBS. Right. And I've been recently wanting to get involved, particularly to help people with the intersection of food insecurity and food intolerance. We took an Airstream full of special diet foods down the East Coast, meeting with food pantry workers, healthcare providers, to really raise discussions and share experiences so that we can learn how best to help patients living at this intersection.
Food pantries now are a staple of our food delivery system in America. In 1980, there were 200 food pantries in America. By 2000, there were 400,000 of them.
And throughout the years, we've noticed that people will leave food instead of taking it all. But the reality is, what you said to me is that you're giving food away that people can't eat that will make them sick.
And so there is exponentially so many more individuals that are out there starving, and their children are going to bed hungry. This is a national problem for hunger in general, but with celiac disease and the gluten-free diet, that's medication.
As a dietitian, it's really important to me that we're giving people food that they'll actually eat, because it's not nutrition until you consume it. We partner with people like Geisinger Health Plan and Health System, PAC Pediatrics, where they screen for food insecurity and they refer their patients to us. And once the patients self-identify, we can work with them on making sure they're getting appropriate foods that they could actually consume for disease management or disease prevention, and that also includes their gut health too.
Food insecurity is so vast. So how do we shift from you have enough to eat to you have the right food to eat for you to be healthy?
Exactly. And you know, for me, it's like it's beyond just like being good for you, but like that actually
nourishes you.
Right?
It has to nourish you. It's mind and body.
Pain,
right. Right.
The last stop on our tour was Charlotte, North Carolina, where we met with Atrium Health healthcare workers to discuss the intersection of food insecurity and food intolerance and how healthcare providers can make a difference.
At this clinic, we serve the underserved, low-income community, so we see a lot of food insecurity, and we do screen all of our patients for food insecurity.
Kind of starting from that framework as we're working with a patient, not necessarily for the patient, and so coming to an understanding that the patient knows what's happening with their body. So if they're telling you that they're having sensitivities to food, starting from a framework, I believe you, let's see how we can work through that. Can we work towards a diagnosis?
So that's where I come in, provide the education to the patients to help identify certain dietary patterns that they can follow that will help symptoms. Once they have that education, we're kind of arming them with those tools that they can then take to the food pantry and make their choices.
You know, some people may view it as though someone's being a food snob or they're being very picky, but if you eat a food that's going to cause you harm or put you in pain, that does the opposite of what our intention is. We want our clients and patients to be not only fed, but we want them to get, you know, good quality nutrition so that they can live productive lives, right? You can't be productive, or you can't go to work, you can't go to school if you're in the bathroom most of the day, or you're cramped up because you're in so much pain. So that's not our intention at all.
We weren't doing this 5 or 10 years ago, and now I see people like you. You know, it's suddenly there's this awareness that has really, I think collectively could really impact, you know, big populations of people.
And focusing on being a team on behest of the patient, so working with dietitians, working with community resources and the practitioners, I think all of us together, we can make some real progress on an endemic problem for our country.
Let's see if I can exit. Okay. We don't want to keep going here because it'll just re-go. Okay, so I didn't have a summary slide or a thank you slide, but thank you for your attention. And I don't know if I have time for questions. Yeah?
For a really interesting talk. I think it's an area that's not always...
Thank you.
Thank you for a really interesting talk. I think it's an area that's not always thought about. So I'd like to open the floor for any questions from the audience, please.
Kate.
Thank you, friend.
Kate, thank you so much. That was a tour de force, and I think is relevant for any dietitian. We need to understand this in the UK at such a basic level. I think one of the narratives that we're seeing now in nutrition is this idea of, you know, ultra-processed foods being demonized. And we understand that when you're at, you know, the edges of society and in food security, those are foods you're going to access. So as dietitians, we want people to have healthy food, but then there's this balance between, and I wonder if maybe you could speak to your thoughts on this, between food access and, I would say, the gentrification of nutrition.
Right.
On the one hand, we have people who have food insecurity. On the other hand, we have people who are maybe paying £600 to have, you know, their stool microbiome analyzed and have an indwelling, you know, continuous glucose monitor.
Exactly.
And I just worry about, you know, where we sit as evidence-based nutrition practitioners in that scale.
Totally. Well, I think, you know, one of the nurses in the videos did the whole mind and body, and one of the things that comes up is, you know, in one of the food pantries that we visited, they got a shipment in of some Yoplait and yogurt, but it was, you know, maybe with like Twix cereal or something highly processed, And the mom was so excited because her child now could fit in with the other kids that had the Yoplait yogurt. So I think it's very nuanced, right? And you know, what's your poison and what's my poison? I think a lot of us had dessert today, and I don't feel one bit bad about that. I enjoyed every bite. It was great for my mental health, I would say. So I guess it's reminding, you know, ourselves, like, to check our own little delusions sometimes, and like, I couldn't have done this if I wasn't privileged, that I could take time off from work. I recognize that. But we do need to check our own privileges, you know, so it's a fine line that we dance. But yeah, there are going to be people where that highly processed food is such a delicacy to them, and it brings them such joy, a nostalgic food from their childhood, that, yeah, it's nice to have both available. And I would say that most pantries have both things available, a nice mix. Yes?
So the question, sorry.
Thanks for a great talk. I thought it was fascinating. And, you know, I think, you know, working in celiac disease, we see it a lot. You know, a lot of patients come up, and I think there's even health professionals saying, you know, oh, well, you can just eat naturally gluten-free foods, you know, and not really realizing the impact that has. So I think it's really interesting to raise it, and also with FODMAPs too. I think a lot of people don't make that association. So in the UK and England, for example, it's a full postcode lottery, whether you get prescription of gluten-free foods or not. But I know we're ahead of other countries too.
Yes, you are.
But my question is, you know, what do you see in America in that side? Is there any like conversation, anything like that, or how far are things down the line there?
You know, it's a constant conversation, but I don't see it moving in that direction. Our national health care, you know, really is for 65 and above, and they cover very little nutrition education. And so getting food as even though it is the only treatment we have for celiac disease, they haven't been able to move that bar, which is really sad and, yeah, wrong, really.
I was just wondering, how did you get the word out to the people that were in those sort of low-income areas? And did you find that it was kind of like tiptoeing towards you? Did you find that not many people responded at first until it was a bit bigger? Because you mentioned a lot of media, but... Right,
yeah, exactly. So initially, my first stop was a local pantry, and there was a couple of pictures. It's called Project Just Because, and they have a gluten-free aisle. So we were able to do a lot of donations there. We also did a lot of industry donations. So like the Celiac Association, through this event, got $2,000 or $3,000 to help because they get a number of calls to support that. The food pantries that we visited along the way had gotten the word that we were going to be bringing special diet foods, so they were able to let people know, because this was planned, 6 weeks in advance. So they had a little bit of time. And then part of it, in one of the food pantries, we got a big donation of Barilla gluten-free pasta, and a lot of people then kind of came forward and said, I actually need this. It's fine line because we can't talk medical condition. They can't talk. It's not a medical situation. So it's like, would you care for some gluten-free pasta? Actually, yes, we have 2 family members with celiac disease. But we weren't able to preempt a lot of it. Yeah.
So with celiac disease and other kind of gastro symptoms, some people can be quite embarrassed by it and feel that they're kind of trying to specialize things, and sometimes they feel that they don't deserve that kind of additional thing, especially if they're going out to restaurants and they always feel like, oh, I need to mention this, but actually, I don't want to.
I told the whole embarrassment piece. I was just reading an article recently. Yeah, so there is a lot of that, but a lot of these food pantries were a little different during the pandemic, where they were giving out things and packing trunks of cars. But typically, it's a grocery store, and that's what they've So patients can self-select, or guests can self-select that visit the pantry. So it's a little bit less, they're not asking specifically for it. And the pantry that I'm affiliated with has a low FODMAP section now too. And that really a lot of people were aware of low FODMAP, and we're really excited to see that. But it's nuanced in layers, stigmatized conditions where there's a lot of work to be done in this.
I think we've got time for one more question. I think we've got time. Do you want to go?
Hello, I just want to say wonderful work that you're doing. I just wanted to kind of talk about your resource that you'd made and kind of in our trust, addressing health inequalities and kind of health literacy is quite a big topic at the moment.
Yes.
I think it's a really good point with the low FODMAP diet as an example of a really complex one. What do you think we as dietitians can do to kind of improve that accessibility? And for example, with your resource, which I thought was fantastic, how can we push for them more, or do they exist already?
I don't really know everything that exists, certainly in that area, but I think it all comes down to asking patients and, being comfortable, and certainly don't put them in an uncomfortable situation. But I tend to be pretty open and, can you read this, or would a picture handout work out better for you? Bringing those people that you're trying to serve to the table and finding out. There was someone's doing some health literacy studies in the U.S., and it was remarkable how low health literacy was in this particular cohort of patients. So you have to know your patient population. When I worked in the city, it was very different than when I worked in the suburbs. So it's going to vary probably where you are. Language barriers, it's sort of kind of getting the community together. It's like, where are the limitations, and how can I use, as my life purpose, my skills and passions to create what's missing to fill those gaps. Are we running over? And I don't want to get in trouble by anyone.
I think we're good. Time for two more. Going to introduce my colleague Florence.
That was really interesting. I was just wondering, at least in the UK, it's a bit of a potluck as to whether you'll be prescribed gluten-free products if you are celiac. So I was just wondering whether you thought means testing should be involved in the process at all.
I couldn't really understand.
Oh, sorry. So
it's probably more a language barrier. Accent.
So whether they should be tested, like a food insecurity should be checked in terms of providing gluten-free products, because it's potluck, it just depends on your GP practice as to whether you'll be prescribed gluten-free products. And I was wondering whether they should do checks into whether somebody is at risk of food insecurity, and whether that should be considered more frequently in terms of the provision of these products on prescription.
Not really sure how to answer that. Sorry.
That's an interesting. We can have a debate about that in the department. Actually, it's an important question. I'm going to go over to Marion.
I don't really understand it. What?
My question was pretty much the same as yours. Was it Florence? In the sense that we've been really lucky up until recently to have gluten-free prescription products.
Yeah.
And what really horrified me is your fact that only a quarter of people who are food insecure follow the celiac diet, which is really something. I don't know if there's enough research on that in the UK, because that's the sort of information we should be putting forward. Now, Claire, who I'm sitting next to here, you're at Rotherham, aren't you? And she's just fought a case to get prescription products back up and running. And I wonder if that should be more of what we're doing, based on things like only a quarter of those with food insecurity.
Yeah.
That's something we're very lucky need to do that. We need to. I don't know whether Claire's got more to say about how you've done that.
Okay. As part of my role in Rotherham with the prescribing, I got asked to be part of a working group that was across South Yorkshire ICB. So I'd gone in to represent Rotherham, because we did still prescribe, but also as a dietitian, so on behalf of the patients, with other medicines management leads from Sheffield, Barnsley and Doncaster. And the outcome is that we've actually managed to keep gluten-free prescribing, not just for Rotherham, but actually Sheffield will be restarting the prescriptions again. Yes. And it'll be the same, in terms of the same units, right across South Yorkshire. So we've got rid of the postcode lottery. I was quite shocked. I think you were, Nick, weren't you?
I was reasonably sceptical and pleasantly surprised that we got it.
I was skipping up and down the corridor when I found out. I was like, yes. So.
I think unless we've got any other questions, I think we can break for coffee. Just thank you again, Kate. That was an incredible talk.
Oh, thank you. Thank you.